talk about treatment of menopausal symptoms and drug-drug interactions in women living with HIV. I have no conflict of interest in regard to this talk. We will talk about indications for treatment, about hormone therapy and drug-drug interactions, and alternative therapies. First of all, fertility, which typically ends in a woman mid-40s, occupies less than half of the adult life. And then, if she's lucky, she has 30 or 40 years in which to do something else. This is written in the book of The Secret Power of Menopause and shows us that it's really an important part of a woman's life. In high-income countries, 1/3 of women living with HIV are of menopausal age. I show you data here from the Swiss HIV cohort study, and the proportion of postmenopausal women tripled from 11 to 36% over 8 years, and 1/3 of women are between 39 and 49 years old. They will be transitioning through menopause in the next 10 years here in Switzerland. Healthcare providers do mostly not feel comfortable in treating menopause in women living with HIV. A UK survey showed that nearly all of primary care providers had concerns treating menopausal women living with HIV. And HIV is treated mostly in infectious disease clinics, and there's little knowledge about gynecology and menopausal symptoms. There's also a fear of drug-drug interaction and pill burden, and there's little guidance in the context of aging and HIV. It's very important to know that women living with HIV have the highest bone loss and risk for osteoporosis. As you can see here in this study, in yellow, those are women living with HIV. They had up to 9% lower bone mineral density at all the bones compared to women without HIV or before menopause. Women with HIV have also more frequent vasomotor symptoms, and they have already an increased risk for cardiovascular disease. So 85% of women living with HIV reported having vasomotor symptoms, and vasomotor symptoms are associated with a risk for cardiovascular disease because they have an impact on the stress levels and on the blood pressure. And women with HIV have already a baseline elevated risk for CVD. So this adds up, and if we treat those symptoms, we can also reduce the risk for cardiovascular disease in our women. So how do we start? First of all, we ask our patient in the clinic, which symptoms do disturb you most? Are it the hot flushes, the sleep disturbance, the joint pains, brain fog like concentration issues, and how are those symptoms impacting on your daily life? Can you go to work, or do you avoid social events because of the hot flushes? And then you also ask, which drugs did you already take and are you currently taking? So menopausal symptoms are not specific, and they can be misdiagnosed as depression or HIV related. So only 12% of women living with HIV are offered hormone therapy. First of all, we can offer topical treatment with estrogen because it has plenty of benefits shown here on the slide. It improves elasticity, it makes intercourse more comfortable. So it can also lead to reduced recurrent or urinary tract infections. And the good point here is it's minimally absorbed, so you can give it lifelong. You don't have to add progesterone, and it can be used in women with a history of breast cancer. As shown here, you have to tell your woman starting this treatment might lead to some discomfort because the superficial cells are renewed. But then after 3 months, there's the great effect. So when do we offer hormone treatment? First of all, it's part of an overall counseling, of course, about lifestyle recommendations, healthy diet, sports, and giving up cigarette smoking. But there's also clear that hormone treatment remains most effective for vasomotor symptoms. So it's better than all the alternative treatments, but it can also reduce the risk for cardiovascular disease, osteoporosis, and for type 2 diabetes and dementia. The risk and benefits, and this is the discussion you have to lead individually with your patients. It varies, of course, with the baseline risk from each individual. So ask for thromboembolism risk in the family, in the history, for breast cancer risk. And those risks, of course, they change with age. and they change with the years since the last menstrual period. So the best window of opportunity would be to start hormone treatment before the age of 60 years. Another point really important in premature ovarian insufficiency or in early menopause, it's clear that those women, they will benefit because of the higher risk of cardiovascular disease and osteoporosis from menopausal hormone treatment. So this treatment is advised at least until the average age of menopause, which would be here in Switzerland, 51 years. If you start hormone treatment, the preferred regimen would be transdermal estrogen with a shale and then micronized progesterone. You can give that for 2 weeks per month, or you can give this daily. If the uterus is there, you have to give it because the protection of the endometrium. An alternative would be the Mirena coil. There are some alternatives like combined patches and combined oral formulations. There's also other drugs shown here on the slide used for hot flashes. And I want to mention that cognitive behavioral therapy and yoga therapy are also shown to be effective. And you can combine them, of course, with a hormone treatment. A new drug, which was just approved by the FDA this March in 2023, its name is fezolinetant, and it's a neurokinin 3 receptor antagonist. So it's blocking the activities of this receptor. And this is a receptor in our brain that's responsible for the regulation of our body temperature. So a new drug, and there's of course no data for women living with HIV. If we come to drug-drug interaction, you know the Liverpool website, it's called hivdruginteractions.org. And you can see that most of the HIV drugs used currently have no interactions with hormones. The older NNRTIs or PIs, they might have a slight decrease or increase in both hormone levels, but this is not important in clinical practice because we treat symptoms and we do not measure hormone levels in our patients. Herbal drugs, they are used sometimes very often, and that's a cultural or family or tradition. And there are so many, you don't have to read them all, but they all have to be shown to be effective with different mechanisms. It's just important to show here that herbal and natural does not mean that they do not have drug-drug interactions. So check the website for drug interactions also in herbals, like for example, St. John's wort reduces antiretroviral therapy levels, and this can be dangerous, leading to a viral rebound. My last slide is about sexual health, and it's a huge topic. And here I really, really want to stress that the conversation is the most important. The conversation with our patient first. How is your sex life? Are there any issues you want to discuss with me? And can I help in any way? The U equals U discussion is a very important part of this conversation. And if so, you can invite her partner, because sometimes in a partnership, they stop to talk about sex because there's an issue and there's an ever-widening gap of not talking, and you could maybe help with that. Offer vaginal estrogen, moisturizers, or psychosexual support. We also use testosterone. It's prescribed off-label, but we use it to increase libido and is a transdermal application, and it's shown to be very effective. So as a summary and for our discussion, I want to say that we have high prevalence of symptoms of menopause in our women, and ask them for the quality of life and what expectations they have from a therapy. Hormone therapy is underused, definitely. Give more information and make a shared decision-making with your patient with a good risk-benefit discussion. And of course, menopausal hormone treatment is not contraindicated in women living with HIV, but we just have very little guidance so far. Drug-drug interactions are rare. Key actions would be for you to offer local estrogen to your patients and offer also hormone treatment in regard to osteoporosis, cardiovascular risk, and sexual well-being. So the future aims of our group within EACTS and WAVE would be to have better guidelines, first on assessment of menopause, but also for treatment for women living with HIV. Thank you very much.